How's it going, folks? It's the Critical Care Coach here. Today I want to go over two topics, SVT and lead placement when you put in a patient on a monitor or EKG, right? So let's start off with SVT, Supraventricular Tachycardia, all right? Now what is that? The heart is beating way too fast. Now some books you read may say 120, others may say 140, 150, but for your critical care exams, you want to know 140, okay? Now, the left ventricle is the chamber of the heart that pushes blood to the systemic system, okay? So when this chamber is beating too fast, it's not getting the right amount of blood to the rest of the body, right? Now, some folks might say, hey, what's wrong with the heart pumping fast, right? It means you're getting more oxygen and more blood to the body. That's not what's happening here, okay? So let's say this is your left ventricle. Normally, your heart rate should be between 60 to 100, right? That's how it's beating. And every time that you're in diastolic phase, which is when the chamber's open and filling, you start to fill up that chamber with the blood necessary to pump out to the body. Let's say, for example, this chamber holds 50 mLs. That's not the number, I'm just going with 50, okay? Now, every time it's open, the left atrium is filling this chamber with the blood needed, and let's say it fills up to 50, and then systolic happens, it contracts, and that blood gets pushed out to the body. That's what's happening to your normal 60 to 100 heart rate. Now, when your heart is beating too fast, over 100, all right, that diastolic phase is less and less, which means that, let's say you have 5 seconds of diastolic phase, 5 seconds for that heart chamber to fill. Now you're cutting it down to 1 or 2 seconds because this chamber is pumping so fast, right? It's beating too quickly. So what's happening is now this chamber does not have enough time to fully fill up as much as it's supposed to pump blood out. So what used to be 50 mLs of blood filling that chamber during the diastolic phase, the opening phase, the refilling phase, now it's 10 or 20 mLs, right? Now, does that sound like enough blood to pump out to the body and be able to feed your tissues and organs with the oxygen that it needs? It's not, okay? So this is what's gonna cause problems, all right? And this is why SVT is such a serious condition. Now, the tachycardia is already bad. Anything over 100 is bad, but now we're talking about 140s and above, okay? So that's even less and less blood filling that chamber and being pumped out to your body, okay? Some things that we need to know for the critical care exam, all right? Where does the SVT originate? One might think in the ventricles, right? It says it right there in the name. No. So SVT actually originates in the atrium, okay? And that's a little trick question they may ask you. You may get tripped up if you don't know this information, so now you know. Don't get tripped up by the word ventricle and think that SVT originates in the ventricles. It actually originates in the atrium, okay? How do we ID SVT on an EKG? Well, you're gonna have a narrow QRS, and what about the P waves? Normally the P waves are not gonna be present, okay? So you're not gonna see any P waves. So you're gonna have a narrow QRS, no P waves, and of course you're gonna have a heart rate of 140 or more, all right? So what's happening? What's the problem? Well, we just discussed it, right? You have a decreased cardiac output. You have less blood is pumping out of that heart, and less perfusion is going around to the body to feed all the organs and the tissues with oxygen that it needs, right? So that's our problem. How do we fix it, okay? Two types of SVT. You have your stable and your unstable, right? Now your stable SVT is when the patient is responsive, they have a normal blood pressure, okay? You wouldn't even know anything is wrong until you saw it on the monitor, right? So you see on the monitor that your patient's at 140 or above, okay? Now you know that you're an SVT. What do we do, all right? A couple things we can do, all right? First line treatment and second line treatment. Let's go over the first line treatment real quick. Now this is vagal maneuvers, right? Some people may know what vagal maneuvers are, right? You're on a plane, you hold your nose, you hold your mouth, you push air out your ears. Vagal maneuver, things like that, all right? When you do things like that and you have a high heart rate, it'll help bring it down naturally, okay? One of the vagal maneuvers that we may do is you can grab a syringe, for example, or a straw. You could pinch the straw, try to have them blow air into the straw and open up your fingers, or you can use a syringe. You have them blow into the syringe and try and push the syringe out, okay? That's one little trick you can use. Now, if for some reason this is not working, you can also double down and add two types of vagal maneuvers, all right? You have them blow all the air out of their body and try and expel this little syringe, and then while they're laying down or sitting down, lift up their legs very quickly, and this should help drop their heart rate, okay? 2 or 3 things right there you can do for vagal maneuvers. Now let's say vagal maneuvers is not working. Now what? Okay, so now we have to turn to medication. Medication is our second line treatment, okay? One of the most common medications that you will see is adenosine. Now there are others. calcium channel blockers, beta blockers, digoxin, other medications that you can give. But primarily, they tend to give adenosine first, right? They go straight to the heavy hitter, right? Now, adenosine, you can give up to 2 doses. When you give adenosine, you're going to start with your 6 milligrams, and then 1 to 2 minutes goes by. If that doesn't work, you can give another dose of 12 milligrams, okay? One thing you may see in your exams is a very tricky question where they won't put adenosine, but they'll put amiodarone. Now, amiodarone can be given during SVT, but it's not a primary. It's a secondary medication after you absolve all the first-line medications, okay? Your calcium channel blockers, your beta blockers, your digoxin, your adenosine, etc., okay? Now, on these questions, you may see them have Pepsid, calcium channel, some calcium channel blocker, and then let's say aspirin and amiodarone. Now, because we're so used to amiodarone being a cardiac medication, we're going to run to that and completely bypass and forget about everything else we saw because we didn't see adenosine. All right, so don't have your mind set on the adenosine and have tunnel vision. Okay, they may trip you up and see if you know all the other first-line medications for SVT. Okay, not thinking that amio is a second-line medication that we only give after all the first-line ones are not working. Okay, some important things you need to know about adenosine. First, let's warn the patient. All right, adenosine is going to make the patient feel a little icky. All right, we don't want them to feel icky. Let's warn them, hey, you're gonna get this medication. It may make you feel a little funny, but it's gonna be okay. It's only gonna last for a few seconds and then you'll be all right, okay? Another thing you wanna look out for, and anybody who knows adenosine knows that to watch the monitor right when you push the medication is because you're gonna have a very short asystole period, okay? And it should only last a few seconds and then the heart rate should restart right back into normal sinus, okay? But if you don't know that, you might get alarmed and start screaming and yelling, oh my gosh, what's going to happen here, okay? But just know that you may have a very short, brief asystole period before the heart rate starts up again, right? What else do we need to know here? Let's go over the actual admission of this medication, which could be very tricky. Now, adenosine has a very, very short half-life, literally seconds, right? You'll push it into the patient and seconds later, it loses its potency before it even reaches the heart, okay? So there's something that we need to do to ensure this medication gets to the heart very quickly. So this medication needs to be pushed rapidly, okay? Very rapidly. And how do we do that? We're gonna use this handy dandy stopcock right here. Okay, you may have seen it. It has the 2 chambers where the medication and the saline syringe are gonna go. And then this will be the tubing that goes to your patients, okay? It should be straight to the J loop, all right? We're not putting this on some long tubing. This is going straight to the J loop, straight to the IV, all right? No additional tubing necessary. It's gonna cause the adenosine to lose its potency way before it reaches the heart, okay? So what we're gonna do here, let's talk about the lock mechanism here. This blue device has a locking mechanism. Wherever this blue mechanism is pointing to, that particular chamber is closed. So if you point it this way, it's closed off to the patient. This way, closed off to that chamber. This way, closed off to this chamber. Now, the way you want to set this up is, hopefully, you should have more than one person in the room with you, okay? One of you can set up the adenosine, draw it up, and the other one can set up the stopcock, right? That way you save time. That way you get this patient out of SVT quicker, right? The way we'll set this up is your flush is going to go this way. The direction is pointing towards the patient. And then your medication will go up here, all right? That's how it's gonna be set up. Ensure that when you start, the lock is gonna be off to the syringe, off to the flush, all right? And then you're going to very rapidly push, turn quickly, flush, turn quickly and flush, all right? So again, you're gonna start off with it, off to the flush. You're going to quickly administer the adenosine, quickly turn the lock, so you turn this off, and bolus this little syringe here. Flush it very hard, okay? Because it has to reach the heart before it loses its potency, okay? The other type of SVT is your unstable SVT, right? Now this patient's gonna have chest pain, palpitations, low blood pressure because you're only getting a little bit of blood coming out of the heart, so obviously the pressure is gonna be a little bit low. They may have shortness of breath. They may even be unresponsive, okay? So these are the signs that this patient is unstable, and we're not doing these first-line medications. We're not doing this first-line vagal maneuver. We're going straight to synchronized cardioversion, okay? Now, the point of the synchronized cardioversion and the point of the adenosine is you want to stop that SVT, you want to break that and see what the underlying rhythm is that the patient's having, all right? So when it comes to synchronized cardioversion, pretty much you're going to shock the heart back into its normal sinus, okay? Now, when you have patients, I'm going to show you on this little drawing here. I'm not an artist, never claimed to be, so don't judge here, don't laugh. But you may have a patient who has either they're very, very muscular, all right, or they may be very big boned, okay, and they have a lot of extra skin tissue. Now, when you put these pads on, right, you are going to have a thicker layer of fat tissue or muscle tissue, okay? And we want this to be as close to the patient's heart as possible. That way we can actually shock it right away. So what you may see the provider do, I'm going to backtrack real quick. Make sure that this patient gets sedated, right? Because when you shock this patient, it's going to hurt. So make sure that this patient is getting some prop, they're getting something to sedate them and so they don't feel this shocking as much as they would if they weren't sedated. So just ensure that the provider sedates them, okay? Sometimes providers forget things and you have to remind them, okay? So as I was saying, they may grab like a towel or some type of thick cushioning to place on top of the patient's chest, on top of the padding to push down. That way you close the area, the tissue area, that way the shot gets delivered even better. Okay, because you have all that fat or muscle, they may want to put their hand there to press down the padding. That way the shot gets delivered more effectively, okay? So that's something to keep in mind. That's not something that you're going to do. That's something the provider is going to do, all right? And that's just a little trick and tool that they use. So while we're here, let's talk about the monitor and the leads. This is a regular monitor placement for the leads. You're just monitoring them. Your order says to monitor their heart rate, or their respiratory rate, things like that. And this is just to keep an eye on them while they're in your critical care sector, okay? Some memorization tools that you may want to keep in mind when using these leads. White right, clouds over grass, smoke over fire. So as long as you remember white right, clouds over grass, you'll know what's happening on this right side right here. And on the opposite side is going to be your smoke over fire. So your black over red, okay? And then your brown, this is supposed to be brown, is going to be center, okay? Now, when putting this on, you may have, you may have an admission, you may have en route to go pick up another patient, you might have to drop this one off, you have all these things going on, you may forget the order of things, you may mix things up. I've seen it happen, okay? So just take the few seconds you need just to remember the memorization tool and put things in the right location. Otherwise, you're not going to get the right readings, all right? So again, white is right, clouds over grass, smoke over fire, and your brown goes in the middle, okay? This setup over here is for patients that are getting EKG, ECG, all right? This is more commonly fumbled in the field or in the hospitals. Sometimes people are doing this in a rush. They might not put the stickers in the right placement. They're not getting accurate reading. They got to fumble with it, go back and forth and play with it to try and make sure that the EKG monitor is reading it accurately, okay? So let's just go over really quickly, that way you know where things go. Before we start with the V1 through V6 leads, we'll talk about the extremity leads, okay? So you're gonna have leads for each extremity, and you wanna put them in the most distal part of that extremity. So you put the lead in the wrist, in the ankles. If you have a patient who is an amputee, you'll put it in the most proximal part of that particular extremity. If they don't have that extremity, we'll just go to the shoulder or go to the femoral area, things like that, okay? But try to put it in the most distal part of that extremity or where the extremity would be, all right? 45 is the magic number I want you to remember here when thinking about EKG placement. 45. As long as you remember that, everything else should come relatively easy, all right? So your V1 lead is going to go on the right side of your sternum in the 4th intercostal space. Now, it may seem a little tedious to sit there and feel and figure out where the intercostal space is, but you want to be as accurate as possible when doing this EKG. When you're doing the EKG, it's because something serious is happening, right? They may be having some chest pain, some tightness, and you want to see what's going on with that heart. So why mess around and not put things in the right position and not get the most accurate reading, okay? So just take the few seconds you need to put things where it really needs to be. So again, V1 is gonna be on your right side of the sternum in the fourth intercostal space, all right? Right there, nice and tight up on the sternum. And your V2 is gonna be right beside it, symmetrical. Fourth intercostal space, V2, left of the sternum, all right? Now going to the V3, we're gonna skip that for a second. We're gonna skip the V3, we're gonna go to the V4. Now your V4 is where the fifth intercostal space comes in. This is gonna go on the left side of the chest because we know that the heart, the apex kind of divots to the left side of the chest. It's not dead center in our chest, it kind of divots to the left. So our V4 lead is gonna go in the fifth intercostal space, mid-clavicular, all right? So this is where your clavicle is. So right down the middle of your clavicle, should be right along the nipple line. It's gonna go right there. Fifth intercostal space, mid-clavicular. Now, if you have a male, that should be relatively easy to find. If you have a female, you just may have to lift that breast tissue with the back of your hand, never the front of the hand. Lift that breast tissue with the back of your hand, feel for that intercostal space, and make sure you place it in the right location. Then we can double back and get that V3 where it needs to go. There's no intercostal position, it just needs to go in between the V4 and the V2. Now we're gonna skip the V5 and go to the V6. The V6, we're gonna stay along that fifth intercostal space. Now we're gonna put this V6 sticker on the mid-axillary line. This is right here, right down the armpit, mid-axillary, on the left flank over here, right? So place that in the mid-axillary fifth intercostal space. And then we'll go back and do the V5, which is just gonna go in between the V4 and the V6, also staying on that fifth intercostal space, okay? Now, while speaking of the leads and possible MIs, just know that just because you have a normal EKG does not necessarily mean that this patient is not having a heart attack. It is possible for a patient to have a normal EKG but still be having a heart attack, all right? And this is why you have to get labs, right? We'll check the cardiac, see if there's any cardiac markers rising, and that's the indicator that we have MI, a heart attack. Which cardiac markers are we gonna look for? We have the myoglobin, which 2 hours after the initial MI is when you can start finding that cardiac marker. Your troponin, which is the more common one that we look for, and that can start anywhere 3 hours after the heart attack, and then your CK is 6 hours after the heart attack. 2 times 3 is 6. Just think of it that way, okay? And so again, just because you don't have a STEMI or an NSTEMI does not mean that they don't have a heart attack, all right? And we'll stay on that topic for a second. Let's say the patient they find out that the patient has a occlusion, they go to the cath lab, they get a stent placement, they come back to the floor, they go to the ICU, whatever it may be. Just know that hours after the stent placement, you can still have increase of cardiac markers, right? So don't be alarmed and say, oh my gosh, this patient's having a heart attack once again. No, that muscle is still damaged, the heart's still damaged, this sustains some trauma, so now it's still releasing those cardiac markers, okay? So don't be alarmed if you still see those markers rising. In addition to that, you may have the patient be bradycardic, right? They may have a heart rate in the 50s, 60s, high 40s, things like that. Don't be alarmed, that's expected, okay? If you feel more comfortable, let the provider know, hey, listen, this is what's going on. I know it's normal, but it's like in the mid 40s. Are we still okay with that? Or should I, put a monitor on him and make sure everything is okay? Just find out, all right? When in doubt, whip it out, the communication, all right? What else here? Speaking of the sternum, there's a bone right below the sternum, which is called the xiphoid process. And I want to bring this up because I've seen folks have improper hand placement during compressions, doing CPR, okay? It's very important that while you're doing CPR, your hands should be in the proper placement, which is in between the nipple line, okay? You don't want to be too low on that sternum because although it is good if you crack some ribs during CPR, if it happens, it's because you're doing proper compressions, right? That's not a bone that you want to break. That xiphoid process is very small, and if you crack that puppy off, those jagged pieces can start getting pushed into the liver if you continue compressions in that area, okay? And you don't want to stab that liver with those jagged pieces of that bone while you're in the middle of doing improper compressions, okay? Placement of the stickers for the EKG. You may find yourself having a little hiccup if they have excessive hair, right? They have a wool sweater on kind of thing, you know? If they have a lot of hair, you may have to shave a little bit of it. You may have to really press down to get a good stick on it, all right? And they may be diaphoretic, all right? They may need to have a little wipe down with some tissue before you place those little stickers on because they won't stick properly, all right? But once you get all these stickers sticking properly, your EKG monitor is going to let you know, all right? It's going to let you know either this lead is off, that lead is off, something's going on over here, and then in the top right corner, you're going to have your little three circles. You're going to have your red circle, your yellow circle, and your green circle, right? Once all those circles start to get moved over to the right and the green circle starts to light up, that means you're good to go. You're solid, okay? Just ensure that your patient is not moving around too much while trying to get this EKG because you're going to get artifact. So let your patient know, hey, listen, I'm about to start this this diagnostic test real quick. I need you just to relax, don't move just for a few seconds so I can get a proper reading. And then once everything is lined up properly, you hit that rhythm strip, get your proper rhythm, get the information you need, upload it into the system so the provider can see it, and you're good to go. They can move all they want, all right? One last thing I wanted to go over, excuse me. Speaking about drawing up medications, right? Most medications that you see are gonna have a little vial. And we're accustomed to drawing up air into the syringe that we're gonna need. Let's say we're drawing up 2 mLs of medication. We're gonna draw up 2 mLs of air into that syringe and then push that air into the vial, pressurize it, and make it easier for that medication to be expelled into our syringe. Great, perfect, that's what we know, right? Every now and then you may come across a different type of vial, which is this one right here. Now this is expired, there's nothing in here, okay? It's garbage. So this vial is very different than the ones that you may be used to seeing. The other vial you may see is the one you have to break off, use the filter needle, right? That's the third kind of vial. But this one right here is a vial that you are not going to push air into, right? Reason being is because it's hollow back here, right? There's a little rubber stopper in there. And if you push air into this vial, it is possible for you to blow out that rubber stopper and blow out the medication completely out. And that'll just be a waste of medication, right? So for this specific vial, all you need to do is draw up the medication without pushing the air into it, right? Whatever you need to draw up, you draw it up and then discard the rest. Make sure you waste it. Make sure you get your second signature. Or if you're in a situation like SVT or the patient's having a seizure, you may have a little bit of extra in this vial. Don't discard it right away because the provider may order, hey, let me get another 5, let me get another 10, let me get whatever the medication is. Don't quickly discard your vials because the provider may say, hey, I want an additional dose because it's not working, okay? But just know that this vial right here, which is your very thin guy with a hollow back, we're not gonna push air into this, okay? As always, please like, subscribe, share, tell a friend to tell a friend, repost. And if there's any information you guys want to know about, anything critical care related, medical related, go ahead and drop it in the comments and I'll try my best to get to it like I did with these guys over here, all right? You guys have a great day and God bless.